Thanks for joining us for Shared Management of Psoriatic Disease. I'm Joe Merola, a rheumatologist in Boston. There have been a lot of other concepts shared throughout the last two modules. Hopefully this is a little bit of a way to tie things together and think about an approach to management moving forward. So what's the concept? Hopefully this is not an overwhelming comment, but just to say that psoriasis and psoriatic arthritis and psoriatic disease can be complicated. And what do I mean by that? So we've heard a little bit from Evan and then Elaine about the manifestations of disease. And there's quite a bit of heterogeneity when we think about psoriatic disease. And our approach to treatment depends on many different factors, including which domain of disease is present in a given patient, what the severity of those domains are, how much each of those may impact the patient's quality of life, how much it bothers them. And as you've heard, and as we'll cover in some of the cases in the next module, the treatments may variably face these different situations. So that's one layer of complexity. The next layer of complexity is what Elaine covered, which are the multitude of potential comorbidities in a given patient and how that may also inform our treatment decisions, including compatibility of treatments. And then with regard to the patients, there is, we may come up with a treatment we think is sort of the ideal, maybe facing the particular combination of disease at hand, and they may have their own preference. They may be needle phobic. And then, of course, we may all agree in the room, and then we have to deal with the payer and what we have actual access to. So there are a few different layers of complication. And we'll talk a little bit about some ways to bridge that gap. In terms of the way that dermatologists and rheumatologists consider the disease, I think hopefully I'll convince you in the next few slides that from the patient perspective, both the skin and the joints matter. And so we have to really think about that when we're approaching the care of our patients. So just building a little more about the concept, despite progress with multiple new treatment options, there still remains some considerable variation in the quality of care from diagnosis, time to referral, treatment, and follow-up care perspectives. And so coordination of care can bring different perspectives together, can help sharpen treatment plans, and ultimately, we're all aligned in wanting to improve and optimize the care of our patients with psoriatic disease. So to the point that both skin and joints matter to patients, if you look here on the y-axis, we have the PASI, right? So a measure of skin severity. And you can see as you go up to the top, we have increasing skin clearance. On the x-axis, we have the DAPSA, which is essentially a measure of joint disease or joint domains in a composite measure. And as we go to the right on the screen, we're improving the joints. And so what we're really looking for here is to get patients into the red zone, which is the optimization of both skin and joints. And this is with the metric of EQ5D, so looking at health-related quality of life. So what this says is that really our ability to optimally or to optimize health-related quality of life is dependent on the successful treatment of both the skin and the joints. And so if you were in any way overwhelmed by Elaine's presentation of all of the variety of comorbidities of disease, I think this is hopefully a diffusing moment where it's true that we have to think about all of these different domains and that they're all incredibly important. And so we have to at least own the idea of having a discussion with the patient, but then we also get to own the idea of sharing that wealth with other providers and building a team. And so, ultimately, if I'm sitting in my dermatology camp, I'm going to own the skin treatment. You can see here treatment of psoriasis, but I also get to, in addition to doing some screening, I get to refer and build a team on behalf of my patient. And so here you can see we have the cardiologist involved, we have the primary care physician involved, we have the rheumatologist involved, we have the the psychologic support, we have the GI folks to help us with the fatty liver disease, for example, with the potentially concurrent IBD. So just looking through this slide, it's meant to be both overwhelming and hopefully a reduction in your anxiety level when thinking about the approach to this, and really just think about that sort of helping a patient to build their team. So what are some of the challenges to the process of care in psoriatic disease? So limited awareness of psoriatic arthritis among non-rheumatologists. Hopefully Evan helped to demystify a bit about the disease state itself. We'll talk about some ways to approach screening the next few slides. The fact that we tend to be siloed in our approach to care, and there is in general limited coordination of care between specialties, and we hope to break down some of those barriers. There can often be a late referral and diagnosis, and so again, thinking about how we can start to own more of the early diagnosis, particularly of the psoriatic arthritis piece, and then the comorbidities management. So putting my dermatology hat on here, I'm going to talk a little bit about some of the gaps. So when we think about psoriatic arthritis screening, I put the who, what, when, where, and why. So the who. And I put who, me. Am I the one that's supposed to be doing this screening? And the answer is yes. But there are many different ways to think about this screening, and honestly, we'll talk about this in a moment, but this could be done while the patient is sitting in the waiting room using a validated screening questionnaire, for example. What is it that we're trying to screen for? So in many respects, we want to get at inflammatory versus non-inflammatory arthritis and think about referring appropriately. Again, we'll talk about that. How frequently do I do this? One could make the case for doing it at every visit for a psoriasis patient. I would say at least we're doing it once or twice a year. And we know that a delay as short as 6 months may impact damage and function in patients in terms of delay to the diagnosis of psoriatic arthritis. And so that's a reasonable time frame. And it really is a low burden to screen. It takes just a few minutes, and again, we'll talk about that. It can be done in a variety of different settings, and again, the reason for doing it, I've heard this quoted before, this concept of time is bone, just thinking that the clock is ticking and we want to get these patients to appropriate treatment in a reasonable time frame. We have to become more comfortable with the psoriatic arthritis concept, and that can be a barrier for some dermatologists and for non-rheumatology providers. And then we may be variably familiar with the actual management and treatment piece, and we'll demystify that. So for the rheumatologist, what are the rheumatology gaps here? And so there may be a little bit less comfort with the dermatology sort of differential diagnosis of a presenting skin eruption. Especially I'd say some of the non-obvious stuff. So, a plaque on the elbow, we may not have so much differing opinion on, but sometimes seborrheic dermatitis in the scalp, for example, is this psoriasis or an overlap? Inverse or intertriginous psoriasis, and some other variants that may be less obvious. We can become more comfortable as rheumatologists with the use of topicals and sort of optimizing the skin management on top of maybe what's already working for well-controlled joints. Thinking about drug-induced eruptions, for example, the anti-TNF induced psoriasis. How do we approach that? And then appreciating the skin, appreciating that the skin matters to patients and that it has significant impact on quality of life, and that we have to really get patients to a good place with their skin, even if we're doing a great job with their joints. For the non-rheum, non-derm, for other healthcare providers, similarly, just getting comfortable with the rheum-derm space, with inflammatory arthritis and inflammatory skin disease. For other specialists, many of our patients with psoriatic arthritis, Evan and I have had this discussion before, may be presenting to the podiatrist for recurrent plantar fasciitis. Making that connection between the psoriasis and the presenting signs. The chronic back pain being diagnosed as inflammatory back pain in that context, for example. This was a nice study actually presented by Elaine a number of years ago, and you can see the reference. And this was a group of patients with psoriasis who were referred with musculoskeletal pain to a combined clinic. With a derm rheum combination. And you can see what their diagnoses turned out to be. About 41% in fact did have psoriatic arthritis, and then you'll see from there some osteoarthritis, crystal disease, and even overlap. The indeterminate could represent multiple things, including likely pain syndromes, fibromyalgia, and other diagnoses. So we're really going to focus our attention on screening for the next few slides. And it was interesting, so at least one study has shown up to 41% of patients with psoriasis have undiagnosed psoriatic arthritis. I think a slide from Evan earlier quoted 15%. So there's obviously a range reported, but hopefully this is a bit of a call to action, in particular for the dermatologists, that we need to be doing a better job of screening and getting our patients to appropriate care. With regard to screening, there are a variety of options, and one of those options are already validated screening questionnaires that exist. There are a few listed here, including the PEST, the PACE, the TOPAZ. Let me show you one that I think is a little bit easier to use. This is the PEST screening tool. You can see it has 5 questions. You actually don't need that little homunculus on the side there. And a score of 3 or more indicates that we should be considering referral to a rheumatologist for a diagnosis. And this is available, so the GRAPPA group, GRAPPA, has this available in a free downloadable app. It's available in something like 20 languages for patients to use. And the other thing to mention is this does not have to be done by you necessarily in the room. This can be done while the patient's sitting in the waiting room or sitting in the room waiting for you to come in, administered by another staff member, for example. So this is really something easy and highly feasible in that regard. When some of my colleagues ask, well, what is it that I should be asking about in the room? How do I ask about psoriatic arthritis? And we published a number of years ago this screening mnemonic to remind folks of what it is that we're trying to get at. So there are a few different, essentially 3 questions, or 3 or 4 if you can remember a 4th. So this is the easiest PSA tool. So we ask about P for pain in the joints. S, a qualifying question about stiffness. So prolonged stiffness after a period of inactivity often makes us think a little bit more about inflammatory arthritis. And so that should be a tip off. You see here after 30 minutes or so. If you can remember a second S, asking about a sausage digit to suggest dactylitis, and that is a very specific feature of spondyloarthritis and psoriatic arthritis that can be helpful. A for axial disease, so same thing, asking about low back pain and qualifying that with the stiffness again. Does it improve with activity and when you get moving? And 2 out of 3 of those should prompt you to do more formal screening or think about referring. So I'm part of a group called PACMAN, the Psoriasis Psoriatic Arthritis Clinics Multi-Center Advancement Network Consortium. And both of my colleagues on the line are also part of PACMAN. And this is a group that has really looked at one of the ways to try to bridge the gaps we've mentioned, and that's in a combined trying to facilitate combined clinic models. And I'm going to talk a little bit about that as at least one way that we might start to really bridge the gap. And so the mission of PACMAN is to, again, try to optimize clinical care through these multidisciplinary collaborations that include education, like what we're doing here, but also you'll see the second bullet point down, which is to try to support the formation of effective combined clinic models, including, and very importantly, local, regional derm room partnerships. And I would expand that to say local, regional, or interdisciplinary partnerships, not just between even derm and rheum, but all of the multitude of specialties that touch on psoriatic disease. What are the benefits to some of these combined models? So again, it's optimizing diagnosis and treatment. We know that there's increased patient satisfaction with these models and improved patient buy-in. It can be very much professionally rewarding. And I have to say, I can ask my colleagues as well to comment on this later who have these models. But the the professional rewarding piece, to be able to interact with a colleague and to learn from them and to share thoughts, it really adds a whole layer to the experience of a busy day. And I think many will experience this, if you engage in some of these interdisciplinary approaches. And again, there's a lot of education inherent to this. So what do these look like? There are very formalized models, including a true combined clinic where a dermatologist and a rheumatologist, or a dermatologist and another provider walk into the room at the same time seeing a patient. It's a little less common in the private practice setting. Evan has made this work and actually has a combined clinic in a private practice environment. But again, there are lots of different models for this. And so what do those look like? Again, it may be a formal combined clinic that happens with some frequency. It may be in tandem, but on the same day where the patient sees one doctor and then the other sequentially. It can be a virtual model, and in the current era, that certainly is becoming a more viable method as we all become more comfortable with virtual care. It may be monthly meetings, so bringing cases to maybe a grand rounds or two practices getting together on a virtual platform to discuss complex cases and learn from each other and optimize care through that model. I think increased communication is a key element, and we're going to talk about that a little bit more. But facilitated communication, I think, in many respects, may help get us to where we want to be, and that could be anything from picking up the phone to texting with your colleague, to facilitating what it is that we capture in an EMR template or in the note that the other person wants to or should or need to hear in making their decision when they're seeing the patient in front of them. And so with regard to challenges, none of these models are without their challenges. Certainly scheduling can pose a challenge. Billing models can vary based on the arrangement or even potentially state by state or practice by practice. Finding the right space to be able to pull this off can be a challenge for some groups. And then there are certainly other challenges, including alienating referring providers, for example. And to that end, we've tried to approach what some of those barriers might be on our website, looking at a combined clinics toolkit. So I'd welcome anyone who's interested in looking at some of these models. You can see on the bottom right, there is a web link. There are toolkits for how to think about approaching these combined clinic models, as well as some electronic medical record templates, including note templates that you're welcome to download and make your own. Find ways that you think that would help facilitate your documentation between providers. This is a little glimpse into what those toolkits look like, with pearls and pitfalls, and a little bit of insight into what may help. And we're certainly welcome to receive any feedback, questions, comments from that website in helping you to facilitate your combined clinic model, whatever that may be. This is what the toolkits look like in terms of the note templates. So for example, in the dermatology note, you may embed or have a dot phrase for the pest screening questions that you can bring up quickly and document. On the rheumatology note, you may see or embed a treat to target guideline for the skin to remind you of what, for example, the National Psoriasis Foundation treat to target guidance is on body surface area, so that if your patient is not meeting that target, it's a reminder to collaborate with your dermatologist and think about how to optimize the treatment of their skin, for example. So in summary, we talked a little bit about how psoriatic disease can be complicated, but one of the, we believe, best ways to meet that challenge is in a combined approach to care, multidisciplinary method. Psoriatic arthritis screening is key in really preventing damage and improving quality of life for our patients with psoriasis who may be developing psoriatic arthritis, and remembering that time is bone. One easy way to screen is to ask about those PSA features and think about using or adopting a screening questionnaire in your practice. We talked about some ways to think about models of collaborative care, including partnerships, including facilitated communication. And then we talked about the Pac-Man website as a resource that's freely available at the website listed here. So that ends our module, and I would invite you to please join us in the final module for cases that will hopefully bring together the work of all three of these modules and help us synthesize it into something that we believe will ultimately help bring patients to the right care. So, thank you.